Thank you for having me. This is a topic that I really enjoy talking about, so I'm looking forward to discussing it with you guys further over the next 45 minutes. I'm going to start out by talking about the epidemiology of behavioral symptoms in patients with Alzheimer's disease, along with identifying target behaviors in the context of your evaluation. And then I'm going to discuss the pharmacological management of behavioral symptoms in dementia, talking about classes of medications, go over some of the current literature, talk about recommended doses of specific medications, and also talk about the adverse effects of the medications that we prescribe. By the end of the talk, I'm hoping that you guys will be able to distinguish between agitation and aggression in dementia, to describe the symptom-oriented approach to treating behavioral symptoms, and also to develop a pharmacological plan for treating these behaviors. As Dr. K mentioned earlier, there are many different types of dementias, and one way to categorize them is by possible etiology. So Alzheimer's disease is the most common type of dementia, followed by vascular dementia, and then probably by dementia with Lewy bodies. So unless otherwise specified, the focus of this talk is going to be on the pharmacological management of behavioral symptoms in Alzheimer's dementia. There are slight nuances in terms of the approach to treating behavioral symptoms when it comes to the other dementia, so I want to stress that I'm going to be talking about the pharmacological treatment of the behavioral symptoms in Alzheimer's dementia. Regardless of the etiology, all dementias invariably lead to global cognitive decline that's significant enough to impact a person's level of function. We see a loss of intellectual abilities, we see an impairment in judgment, we see loss of executive function, we see personality changes, and we also see behavioral changes, which are often referred to as neuropsychiatric symptoms. And this is going to be the focus of the talk today, the behavioral symptoms in Alzheimer's disease. So behavioral symptoms are a common accompaniment to Alzheimer's disease, and it affects 50 to 80% of all patients at some point during the course of their illness. They're associated with greater levels of cognitive impairment, with a more rapid cognitive decline, a lower quality of life, earlier institutionalization, and greater caregiver depression. They're classifiable, which is what we're going to talk about, and they're also treatable, which we'll also talk about in more detail. So before going over this slide, I'm curious to know how many of you work with patients who have Alzheimer's disease. So almost everyone in the room. And of the patients that you've worked with, how many have had behavioral symptoms? So also almost everyone in the room. So this is data from a population-based study of over 1,000 community-dwelling older adults. And the authors sought to determine the prevalence of behavioral symptoms in the older adults with dementia in comparison to those without dementia. And what they found was up to 60% of the patients had one or more behavioral symptom, and that certain behavioral symptoms were up to 4 times more likely to occur in those with dementia than those without dementia. The most common behavioral symptom was apathy, followed by depression, agitation and aggression, and irritability. Would you say that that reflects your experience with the patients that you've taken care of? You know, there are other studies that find up to a 90% prevalence of behavioral symptoms in dementia. So we do see that the majority of patients who have dementia also experience behavioral symptoms. I think this is a really cool slide. This shows the prevalence of specific behavioral symptoms in relation to the onset of in relation to the diagnosis. So you can see that most of the very problematic behaviors tend to occur after the diagnosis, but prior to the diagnosis, there are a number of behavioral symptoms that develop and are important to watch out for. So this is sort of a roadmap of my general approach to managing behavioral symptoms in dementia. I always begin by characterizing the target symptom and then assessing the patient for possible medical causes or environmental causes of the behavior. And if I do discover an environmental or a medical cause for the behavioral symptom, I make sure that that gets addressed. If it's been addressed or I don't find a medical or environmental cause, I always start with non-pharmacological approaches to treating those behaviors. I'm going to start out with a couple of case examples. So the first case is an 82-year-old patient with Alzheimer's disease who's been in a foster home for 2 years. let's say you're a caregiver or you're a healthcare provider that's on call, and you get the phone call from the facility that the patient is agitated and they're requesting something to calm him down. Does that sound familiar? So it sounds very familiar to most of us. So how do you approach this? I always start by defining the target behavior and then getting a precise description of the behavior in an attempt to identify the underlying cause, if there is one present, and also to select an effective intervention. So I want to say that agitation is probably the single most common reason that I'm asked to see a person with dementia. But the problem with agitation is that it's a very broad term, and being such a broad term, it encompasses many different behaviors that can result from many different causes. It can be associated with discomfort from things like physical pain, constipation, hunger, or thirst, in which case the behavior is adaptive. It can be caused by psychiatric, medical, or neurological comorbidities, or it could also be due to the underlying dementia itself just affecting critical regions of the brain. So it's a non-specific term, and whenever I hear it, I don't just stop there. I ask more about what's meant by agitation. It includes things like restlessness, pacing, complaining, cursing, kicking, hitting, name-calling, anything else that you guys would throw out there for agitation. What else what are some other things that might be included in the umbrella term agitation? Anyone? Uncooperative, can't focus,
not willing to eat,
not willing, so resistant to care. So I want to spend more time talking about it because it's also the number one cause for placement outside of the home. I typically begin by characterizing the behavior as either physical or verbal, and aggressive versus non-aggressive. So we're going to talk about each of these. So aggressive versus non-aggressive, and physical versus verbal. Physically aggressive behaviors are the ones that make us worry, right? These are the unsafe behaviors. These are the behaviors that get a person taken out of the home and into the emergency room. It includes things like hostile acts that are directed toward oneself, toward objects, or toward other people. So hitting, kicking, biting, grabbing, and scratching. It tends to occur in later stages of the disease, so in more cognitively impaired than less cognitively impaired individuals. It often occurs during times of close contact, so during times of ADL care. Dr. Horvath had mentioned the example of the patient who needs to shower, and it attempts to get the patient to shower results in getting hit or kicked. So I always say that no one has ever died from not taking a shower. So is it super important that the patient get into the shower that day, or are there alternatives to taking a shower? Could you try a sponge bath or try later in the day? There are all sorts of different things you can do, but times of close contact can result in physical aggression. We see it more commonly in men than in women, and it tends to be more common in patients with a premorbid history of aggressive behavior. Verbally aggressive behavior can also be frightening and get patients sent to the emergency room as well. And verbally aggressive behaviors include things like angry outbursts, making strange noises directed at someone, screaming, cursing, threatening, accusations, name-calling, things like that. So I distinguish between verbal and nonverbal aggressive behavior, so physical and verbal. Non-aggressive behaviors, on the other hand, aren't unsafe in and of themselves, but they can be equally as bothersome and distressing to the caregiver and to other people around the patient, and in that way they can be equally as problematic. Physically non-aggressive behavior often includes repetitive motor activities, wandering, pacing, checking, and there are lots of causes for this type of behavior. And just a couple of examples. Wandering may be due to the patient's attempt to look for home or to look for family. A repetitive behavior may be the patient's attempt to work at a former occupation. And pacing may also be due to restlessness that could be from a side effect to a medication or some other cause. So there are lots of reasons that a patient might be displaying physically non-aggressive behavior. So it's very important to get an exact idea of what the behavior is. Verbally non-aggressive behaviors similarly include repetitive vocalizations, whether that's complaining, repeating words and sentences, constantly talking or calling out. But this is how I conceptualize aggressive behavior, and I think it's a very nice way to take a history from a caregiver or from a family member when it comes to getting a better sense of what the problematic behavior might be. An example two, a caregiver tells you that your patient is hallucinating, and this is a 75-year-old with moderate Alzheimer's disease. As with the other case, it's very important to get details and not to take what the caregiver is telling you at face value. So if the caregiver tells you the patient is hallucinating and you decide to go forward with treating the patient with an antipsychotic, you may be offering the wrong form of treatment. And hallucinations may mean something different to the caregiver than its clinical meaning. So I always want to know, what do you mean by hallucinating? When it comes to Alzheimer's disease, hallucinations are actually not that common. So if the patient is telling you that if the caregiver is telling you that the patient is seeing small children in the room, think about something other than Alzheimer's disease. Think about delirium or think about dementia with Lewy bodies. Delusions, on the other hand, are fairly common in Alzheimer's disease, and the nature or the quality of the delusions tend to be very simple. The themes are often suspicious in nature, so thoughts that the spouse or loved one is having an affair, that something is being stolen from them, like their wallet that they've misplaced and can't find, or that other people are in the house. In example 3, you have a 90-year-old patient and the chief complaint is that they're not sleeping well. This is a common reason for referral to me as well. And sleep disturbance is very common in Alzheimer's disease, but I want to know more than just the patient's not sleeping well. I want to know whether they're having a reversal of the sleep-wake cycle, which is common in Alzheimer's disease, whether they're having trouble falling asleep or staying asleep, and reasons that might be the case. I inquire about symptoms of REM sleep behavior disorder, sleep disordered breathing, restless leg syndrome. I look at medications. Could a medication be disrupting the patient's sleep? Could they be drinking caffeine or consuming some other stimulating substance just prior to bedtime? And are there environmental factors for the patient's difficulty sleeping? I've had several patients refer to me for sleep difficulty, and part of the reason that they can't sleep is because the house is noisy at nighttime. And I also think about medical or psychiatric comorbidities that might be contributing to the patient's sleep difficulty. But there's no way to determine whether any of these are going on without getting more of a history. So if I just hear that the patient's not sleeping well, I'm really not going to have an idea of what it is that might be causing the sleep difficulty, and therefore I won't have a really good sense of how to approach the treatment. And patient, or an example number 4, the referral is for a patient with mild Alzheimer's disease who is being evaluated for depression. This, again, is also a very common reason for referral. And what I try to do is to either establish a diagnosis of major depression or assess for the presence of depressive symptoms that might respond to treatment with an antidepressant, while also ruling out secondary causes for the patient's depression symptoms, and also trying to rule out apathy if possible. And distinguishing apathy from depression is difficult to do because of key overlapping symptoms, but it's very important for family education and also for effective treatment. So how do you distinguish depression from apathy? I'll tell you, it's very hard to do, but apathy is rarely, or symptoms of apathy, rarely the chief complaint of the person being evaluated. They're apathetic, right? So, there's no problem as far as they're concerned, and that can be helpful in determining whether this is depression or this is apathy. In juxtaposition, the patient with depression is going to tell you that their mood is not good, or they're not feeling well. They might be tearful, describing feelings of guilt or hopelessness, and even expressing thoughts of suicide, which are things you really don't see in the person with apathy, who's really content to be exactly as they are. Dr. K mentioned the geriatric depression scale earlier. That's a part of my evaluation for all patients who are being referred to me for cognitive evaluation or for depression. But the GDS does become less valid with increasing levels of cognitive impairment, in which case the Cornell scale for depression and dementia can be a useful substitute. So I thought this was really funny. 'cause that's a comment. Before talking about the specifics of treatment, I want to just go over a few key considerations. Number one are details. They're critical for directing clinical care, not only to help you to identify the target behavior, but also to ensure that the behavior in question is not due to some other cause. The choice of your pharmacological intervention is really going to depend on the targeted behavioral symptom, so you really do need to get an idea of what the targeted behavioral symptom is. And key elements in your documentation, as well as your gathering of the history, should include the nature of the symptom, the severity of the symptom, and the frequency of the symptom, and whether or not there are any precipitating factors. This is probably one of the most useful bits of information I could convey to you, and one that's often forgotten. There are no FDA-approved medicines for treating behavioral symptoms due to dementia. So it's very important that we reset our expectations around what these medicines can and cannot do. And I always let family members know that there are no medicines that are guaranteed to treat the symptoms that the loved one is having. So there is no magic bullet. And more commonly than not, the etiology is multifactorial, so there's more than one cause for the patient's symptoms. As reasoning and language skills are lost as the dementia progresses, behaviors increasingly become the primary form of communication. So is it possible that the behaviors that you're seeing are the patient's attempt to get a need met? Could they be hungry? Could they be thirsty? Could they be fearful? Could they be in pain? Could they be confused, constipated, having urinary retention? These are all important things to consider when you're faced with a patient who has cognitive impairment and behavioral symptoms. Always remember that medicines, when used, should be used judiciously at the lowest dose possible and titrated very slowly, but still titrated up. Keep in mind that age-related physiologic changes do render these patients more susceptible to side effects. Renal function tends to decline with age, which reduces the elimination of medicines and can increase the risk of toxicity. Body fat goes up, body water goes down. This can also influence the pharmacokinetics of medications. So do remember that as a result of this, we need to start at low doses and titrate in low and small increments. When it comes to choosing a medication, it should always be done with complete consideration of the patient's medical history and psychiatric history. If a medicine isn't working, it should be stopped. Don't just leave it on and add more medications. Or if you're treating a patient who is on multiple medications and you're not in the role of a prescribing provider, bring it up to the prescribing provider. Point out that the person's on 6 psychiatric medications for behaviors, none of which are working. And on that same note, you'd be surprised that it happens all of the time where patients get referred to me and they're on 6 different psychiatric medicines, and I work to get rid of them, and we do see improvement in the cognition and the behaviors as well. On the flip side of the coin, if a person was started on a medication, 3 months goes by and they're doing really well, try to either lower the dose or taper it and discontinue it and see how they do off of the medication. Treating behavioral symptoms in dementia is a moving target. As the dementia progresses, the nature of the behavioral symptoms change, and the need for specific medications to treat those behaviors will change as well. There are certain behaviors that are just not going to respond to a medication. These include repetitive vocalizations and calling out. Wandering and exit seeking doesn't really respond to medications. Disrobing, hoarding, and inappropriate voiding. So these are things that typically are not going to respond to a medication. Also keep in mind that there are many classes of psychotropic medicines that have been shown to be effective in treating behavioral symptoms in dementia. And these come from studies that vary not only in number but in quality and also in methodology. And translating small changes in clinical scale scores from these studies into clinical meaning can be very difficult to do. So the direct application of any study results to your clinical practice should always be done with caution. So just because one study says that a certain medication was or wasn't effective really doesn't mean that it is or isn't going to be effective for your patient. That always needs to be needs to be kept in mind, and we'll go over some studies that should hopefully help to clarify some of that as part of the talk. I thought this was pretty funny too. So it says, in a past life you were a bowl of flour, butter, eggs, sugar, ginger, and molasses. And that has nothing to do with the symptom-oriented approach. I just thought it was funny. So we're going to spend a little bit of time talking about the symptom-oriented approach. So in traditional medicine, this graph here on the left, signs and symptoms of a disease are used to establish a diagnosis, which then forms the basis for treatment. So a person who's coughing, has a fever, a white count, and a consolidation on a chest x-ray probably has a pneumonia, so they get treated with an antibiotic. Unfortunately, the same approach really can't be used to treat the behavioral symptoms in dementia, because the dementia-specific medications, of which there are only 4, really don't address the full range of behavioral symptoms that we see in patients who have dementia. So when it comes to dementia, treatments that can successfully alleviate particular symptoms are increasingly seen as useful. So if the patient is presenting with psychotic behavior, treating the psychotic behavior can be useful. If the patient's presenting with anxious symptoms, treating the anxiety can be useful. If they're presenting with depressive symptoms, treating the depression symptoms can be very useful. So you're not necessarily treating the specific dementia, you're treating the specific symptom, if that makes sense. And so that's in contrast to the traditional approach that we take in medicine. Does that make sense? So the symptom-oriented approach begins by defining the target behavior and then looking for a pattern in that patient's behavior that's analogous to what we see in a drug-responsive psychiatric syndrome. The patient who is overly suspicious, delusional, or angry when approached would be categorized into this psychotic category. Patients who are sad, vegetative, or withdrawn, or depressed appearing get placed into the depressive category. Patients who have a labile affect, or accelerated, or euphoric get placed, or even impulsive, will get placed into this manic category, and patients who are worried, restless, or have excessive somatic concerns get placed into the anxious category. So these are the 4 categories to keep in mind. Those categories of behaviors are then matched with the most relevant drug class. Depressive spectrum symptoms treated with an antidepressant. Psychotic spectrum symptoms treated with an antipsychotic or a cholinesterase inhibitor. Manic type symptoms treated with a mood stabilizer, and anxiety spectrum symptoms treated with an SSRI. Does that make sense? So I look at the category of the behavior to match it with a particular drug class. But of course, there are going to be patients for whom their behaviors don't really fall into a particular category. And in those circumstances, I rely on recommendations from an expert consensus panel for agitation and dementia that was published in 1998, and I think it's still very relevant now. Patients who have very mild and intermittent behavioral problems, using a PRN dose of trazodone can be helpful. For more chronic and daily but still mild behavioral symptoms, I consider an SSRI, trazodone, or a cholinesterase inhibitor. But when the behaviors are severe, threatening, and acute, I will consider treating with an antipsychotic medication. So we're going to move on to talking about treatment by specific drug classes. And this is very apropos of treating older patients, because this is commonly a situation that we encounter. Yeah, so it says each capsule contains your medication plus a treatment for each of its side effects. So we'll talk about antipsychotics. So these have been the traditional mainstay for treating agitation in patients who have dementia for decades and decades. But over the past decade, we've actually come to discover that these medicines have some serious side effects. We know now that they can increase the risk of mortality in patients who have dementia, and they can also increase the risk of stroke. So about 10 years ago, the practice of using antipsychotics almost in a knee-jerk reflexive way has changed, and we consider other alternatives to an antipsychotic. But what I will say is I'd say that in some circumstances the baby did get thrown out with the bathwater. Antipsychotics still can be very, very helpful, and there are indications for which they can be used successfully. But for all of the patients for whom you're considering an antipsychotic to treat the behavioral symptoms, an individual risk-benefit analysis needs to be considered and discussed with the caregiver. This is a rule of thumb that I tend to follow. Behaviors that are not super severe and that really don't have any consequence of harm to the individual or to the caregiver, I never prescribe an antipsychotic to those patients. But for severe behavior or high-risk behavior that can result in harm to the patient or to a caregiver, or a patient who's very distressed by delusions or other psychotic symptoms, I will consider the addition of an antipsychotic medication. I always look to the literature. So is that practice supported in the medical literature? There were 2 Cochrane reviews published in the past 6 years or so on the use of antipsychotics in patients with behavioral symptoms and dementia. In 2010, a Cochrane review looked at 5 different randomized placebo-controlled trials of Haldol versus placebo. And what they found was that Haldol, was effective for aggressive behavior, not really for the other behavioral symptoms that we can see in dementia, but specifically for aggression. It was shown to be helpful, but not surprisingly, adverse side effects were more common than placebo. So if an antipsychotic is being prescribed, we must watch out for side effects. But there still is data to support the use of antipsychotics for aggressive behavior. When it comes to the atypical antipsychotics, a 2006 Cochrane review looked at 9 different studies and concluded, similarly, that risperidone helped to improve psychotic behavior relative to placebo. But as with the 2010 review, was less well tolerated than placebo. This is an old study that looked at, it was a meta-analysis of 7 studies published between 1955 and 1987. And what they found was that 1 out of 5 patients with agitation and dementia did show some modest but consistent benefit from antipsychotic treatment. But again, side effects led to discontinuation of treatment in some patients. But I will say that some patients did get better when treated with an antipsychotic medication. The Katie Alzheimer's disease arm study was a very large, multi-center, randomized placebo-controlled trial that looked at antipsychotics in patients who had Alzheimer's disease with behavioral problems, and really did show that hostility, aggression, mistrust, and uncooperativeness did get better with risperidone and olanzapine. What I conclude from these studies is that an individualized approach really needs to be taken. If the behaviors are aggressive, if the behaviors are psychotic in nature and distressing to the patient, a trial of an antipsychotic can be considered, but we need to monitor for the emergence of side effects, which include extrapyramidal side effects, so Parkinsonism, orthostasis, akathisia or restlessness, sedation, metabolic side effects, upper respiratory tract infections, and cardiac events. So I discuss this with all of my patients and all of my patients' caregivers. The other side effect that's important to watch out for is tardive dyskinesia, which is an irreversible hyperkinetic movement disorder that occurs much more commonly in patients on typical antipsychotics and patients who are older than younger. So I always watch out for these side effects when prescribing an antipsychotic medication. I put this slide in here as a reminder that antipsychotics do increase the risk of mortality in older patients with dementia, and they also increase the risk of stroke. So I discussed this with all patient caregivers, and I would say that for most caregivers, they're at the point that the benefit of an antipsychotic trial does outweigh the risk. But there are some patients for whom their caregivers don't want to have a medication like this prescribed because of the risk, in which case we search for alternatives. I don't know how many people in here prescribe and how useful this slide is, but what I would say is if you look at the doses, you'll see that these are small doses relative to the doses we use for younger, healthier patients with schizophrenia or bipolar disorder, the 2 most common reasons that these types of medications are prescribed. So very, very small doses. Moving on to antidepressants, there are 2 indications for which I'll talk about the use of antidepressants. One is agitation and the other is depression. There aren't many studies that look at antidepressants for the treatment of agitation and psychosis and dementia, and most of the studies that have been published are small and don't control for co-occurring depressive symptoms. So overall, the efficacy does remain to be established. There was a Cochrane review that was published in 2011 that said, antidepressants were helpful for some patients, and when compared to an antipsychotic, were better tolerated. So this is a very viable alternative for treating agitation and dementia, particularly if the behaviors are not severe and there's low risk of harm from agitation to either the patient or to a caregiver. The American Psychiatric Association practice guidelines published in 2007 also supports the use of the trial of an antidepressant, particularly in patients whose symptoms are mild and in patients who don't respond to an antipsychotic or are intolerant to an antipsychotic. And I would add in there, or for patients whose caregivers don't want to try an antipsychotic medication. So antidepressants are a viable option and alternative. I would say that antidepressants for agitation make most sense when agitation is driven by a mood disorder. So if the patient is depressed and you think the depression is leading to some of the agitated behavior, if you're using an antidepressant, we should avoid the older tricyclic antidepressants, which have a number of side effects. They're quite anticholinergic and are not well tolerated in older patients. The most commonly used antidepressants are these three, and then trazodone, either scheduled or as a PRN. And with these medicines, much like with the antipsychotics, we start at a low dose and we titrate slowly. When it comes to depression, the present practice is to use antidepressants. And there are several positive studies that say, antidepressants can be helpful for depression and dementia. But there was a study published in The Lancet 2 years ago that compared placebo to mirtazapine to sertraline, followed patients with depression and dementia over 13 weeks, and what they found is that all patients got better, the placebo arm as well as the treatment arm. So the conclusion was, well, they all got better, so it couldn't have been the antidepressant. And patients in all arms, treatment and placebo, did get low-intensity psychosocial intervention. So there were some supportive therapeutic approaches implemented into the study, which probably contaminated the results, but also suggests that maybe for patients with mild depression, we shouldn't jump to an antidepressant. We should try to implement low-intensity psychosocial interventions into our approach for treatment. And if they don't get better, maybe then we can try an antidepressant. So again, medicines aren't necessarily the answer to all of the behavioral symptoms in dementia. The APA practice guidelines and the American Academy of Neurology guidelines do support the use of antidepressants for depression and dementia. Doses are very similar to the doses we use for agitation. Side effects to watch out for: constipation, diarrhea, so GI side effects, nausea, tremor, gait instability, fatigue, falls, nervousness, headaches, so very non-specific side effects. But if patients who are started on an antidepressant develop any of these, consider that it might be due to the antidepressant. We know that due to the pathophysiology of Alzheimer's disease, there's a loss of cholinergic neurons in the brains of those patients. The acetylcholinesterase inhibitors work to increase acetylcholine in the synaptic cleft. There are 3 of them. When it comes to treating behavioral symptoms, the literature is mixed. There's not a lot of data that says these medicines are going to work for all patients, and there's really not a lot of data that says that they're not going to work. So what I would say is that for patients who are being evaluated for for dementia, who have mild behavioral symptoms, it's worth trying a cholinesterase inhibitor because you may see some benefit by way of cognition and by way of overall function. And you may also see some improvement in the behavioral symptoms as well. So if the patient is being referred to me for a dementia evaluation and they incidentally have some behavioral problems, and I'm going to start a cholinesterase inhibitor anyways for the dementia, I'll give it a chance and see what it does for the behavioral symptoms. They're often very helpful for patients who have behavioral symptoms in dementia with Lewy bodies, may actually worsen the behaviors in patients with frontotemporal dementia. These are the 3 cholinesterase inhibitors, and these are the doses that we use. There are a number of side effects that we should watch out for, and they are what you would expect by increasing cholinergic tone in the body. The main side effects that we see are GI side effects, so upset stomach, diarrhea, cramping. Memantine is an NMDA receptor antagonist. It reduces glutamate-mediated neuronal toxicity, which is thought to be involved in the etiology of Alzheimer's disease. We use it for moderate to severe Alzheimer's. Literature is also mixed when it comes to how effective it is for treating the behavioral symptoms. Most of the studies recruited patients for the purpose of testing cognition, not for behavioral symptoms, so these were secondary outcome measures. But what I will say is if you're starting, or if a patient is going to be started on memantine anyways for treatment of the dementia, it's worth seeing what it will do for the behavioral symptoms, particularly if they're mild. These are some dosing guidelines. Mood stabilizers. There are 4 mood stabilizers that have been used for treating behavioral symptoms in dementia that do have some literature that's been published. Valproic acid is used for a number of psychiatric conditions where impulsivity is a problem. And anecdotal reports abound in terms of how effective this medicine, Depakote or valproic acid, can be for treating behavioral symptoms. But interestingly, a Cochrane review that was published in 2009 said, that it wasn't effective. But I will say that these were 3 small studies, and they weren't very high quality studies. Have you guys all heard of Depakote? Yeah. Do you think it's helpful? You've seen it? Yeah. So it's interesting that there are a lot of anecdotal reports, but what is published in the literature says it's not helpful. I think it's definitely worth trying, especially if the behavior is impulsive in nature and there aren't psychotic symptoms present. There were 2 positive studies of Tegretol or carbamazepine. I've never prescribed it for this indication, but I put it in there anyways. These are dosing recommendations. Benzodiazepines and diphenhydramine or Benadryl should always be avoided. There's really no data to support the efficacy, but you will sometimes see, or I at least see, patients with dementia and behavioral problems referred to me on these medications, and I always stop them. Buspar has been shown to be helpful in 2 case studies. It's pretty well tolerated and has few side effects. It's primarily used for generalized anxiety disorder. So if I do see a patient who has dementia who appears to be very anxious, I will try Busparone. And more recently, Prazosin, which is an antihypertensive medication, was looked at about 2 years ago, and at a mean dose of around 5 milligrams found to be helpful for treating behavioral symptoms. Unfortunately, so the NPI was used, which looks at 10 different categories of behavior, but the authors didn't comment on which particular category of behavior improved on the NPI. And a larger study by the same author is yet to be published, but is apparently in the works. When it comes to treating sleep, behavioral approaches seem to be the most helpful. If I've attempted behavioral measures and they're not working, a trial of trazodone can be considered. If I think that depression or anxiety is at play and is causing part of the sleep complaint, I'll try mirtazapine. Melatonin has mixed efficacy in the medical literature. It's pretty well tolerated. If the patient's sleeping during the day and awake at night, I will consider using melatonin. But what I will say is never use an antipsychotic solely as a hypnotic. So if you're a prescriber or a caregiver, never ask for an antipsychotic medicine like Seroquel because you've heard it's helpful for insomnia. So in summary, I always try to start with the non-pharmacological approaches, which I didn't talk about, but I do start there. And I reserve medicines for behaviors that are severe, persistent, and resistant to the behavioral treatments. If lots of medicines aren't helping, I start to discontinue medicines. I always ask myself, can they be any worse off of medications? And is it possible that the behaviors we're seeing are due to side effects? I avoid the bad medicines, which include the benzodiazepines, Benadryl, and in certain cases the antipsychotic medications, and I always start at a low dose and I go slow. If monotherapy or one medicine isn't working, I will consider the use of adding a medicine, but I do it cautiously. Less severe behavior, antipsychotic shouldn't be used. Psychotic behavior or highly aggressive behavior, a trial of an antipsychotic is reasonable, but it should be a short-term trial. And if the patient gets better, it should be stopped. And that's it.